Welcome everybody to our second webinar of the month, or I guess of the fall. Really happy to have everybody joining us. My name is Wendy Gerhardt and I am the Executive Director of Migraine Canada. I first of all want to start off by thanking our sponsors who make it possible for us to develop resources and programs to support the community. A brief overview of today's agenda. I'm going to talk a little bit about Migraine Canada and introduce those of you who are new to us. And then Christie Tait will give her presentation, and then we'll go into a question and answer period. Who is Migraine Canada? We're a national association supporting all Canadians living with migraine and headache disorders. We are federally registered as a not-for-profit corporation and will be seeking our charitable status in the coming months. We are comprised of a board made up of volunteers who graciously are donating their time to really grow Migraine Canada into everything that it can be. I am the only staff. And I'm thrilled to be a part of this community and working really hard to grow the organization to meet the needs of everybody out there. And lastly, but not least, volunteers. We rely on volunteers to help move things forward. If you're interested in helping and getting involved in our organization, please email me at the information is all on the website, but would be happy to chat with you about opportunities. Our vision and mission. So our vision is really that Canadians living with migraine and headache disorders are diagnosed, treated, and supported so their quality of life is optimized. And our mission is to improve the lives of Canadians with migraine and other headache disorders through awareness, support, education, advocacy, and research. Fairly certain you will see those words a lot in everything that the Migraine Canada does. And as I just mentioned, those are our strategic pillars. We have 5 of them, and everything we do a stress test against each of those to make sure that we are actually doing the activities and delivering the programs that touch on each of those words: awareness, education, support, advocacy, and research. Call to action. For those of you that have not signed our petition, please join our growing community. You can join it off of our homepage, migrainecanada.org petition. And this, in addition to growing the community, this also will give you, give us access to email you with upcoming events, new content to our website, new news, new approvals of medications, of services and that kind of thing. So I encourage you to join the community and let's really grow migraine and the awareness out to the common public. And with that, I'm going to now just quickly introduce Christie, who is our keynote speaker, and then turn it over to her. So Christie obtained a Bachelor of Biological Science from the University of Guelph, a Bachelor of Science in Nursing from the University of Toronto, and her Master of Nursing and Primary Healthcare Nurse Practitioner certificate from Ryerson University. She is the Director of the Headache Program at the Neurology Centre of Toronto and a clinician at the Toronto Headache and Pain Clinic. Outside of clinical care, she delivers educational programming to healthcare providers with an interest in headache and migraine management. And she also hosts a migraine blog site, and her website is www.christietait.com. And Christie's area of clinical expertise is the diagnosis and management of headache and concussion. She uses a holistic approach to patient care that integrates behavioral and lifestyle changes with pharmacological treatments. She is passionate about improving access to quality of care for headache and migraine patients. And with that, I will turn the podium over to Christie to share her presentation.
Thanks, Wendy. Okay, thanks everybody. I want to thank everybody for joining me on a Monday night. The clocks went back, it's dark. So I'm very happy to have all of you here. This is an area that I'm extremely passionate about. It's near and dear to my heart. And I'm very excited to be able to do this presentation for Migraine Canada. So tonight I'm going to talk about the misdiagnosis of migraine. So just a disclaimer, this webinar is to provide information, not medical advice. The information discussed may not apply to your own situation. So if there's any questions regarding treatment, then this is definitely something that should be discussed with your healthcare provider. So what are we going to talk about tonight? So we're going to go over some of the myths and discuss some of the false assumptions and inaccuracies surrounding migraine. We'll look at some common misdiagnoses and explore some of the pitfalls in diagnosing migraine and why it may take so long for a migraine sufferer to be properly diagnosed. And then we'll talk about some of the misconceptions. So we'll learn how some commonly held beliefs may delay treatment or in fact could even worsen migraines. So we'll start off here with the myths. So myth number 1, migraines are just bad headaches. So migraines are in fact a neurological condition. It's an incredibly complicated process, and believe it or not, despite how long we know they've been around, we're still learning a lot about this process. So it involves nerves, blood vessels, and different neurochemicals that are all playing a role in this migraine event. So the headache, the actual head pain, is really only one part of the migraine event. So there's a great webinar on Migraine Canada's site by Dr. Elizabeth Leroux that goes into the science of migraine. It's all in your brain. So I do encourage you to take a look at that for more details. So a migraine is not just a headache. So the entire migraine event can last many days. The headache phase consists of numerous symptoms aside from just a headache, and it's a highly variable event. It's a very unique thing for each sufferer, which is why maybe sometimes people don't identify that they might have migraines if it doesn't fit into all of the things that they perceive. So this timeline, I think, is a nice illustration of some of the things that can be going on during a migraine. So there's a prodrome period. This can go on for hours up to days. And this is when migraine sufferers might talk about changes in their mood. They may feel fatigued. They might have a little bit of increased sensitivity to certain things, sounds, or things in the environment. And then you progress to, if you're one of 1/3 of migraine sufferers that experience an aura, so it's not the majority of migraine sufferers, but the aura phase tends to last about 5 to 16 minutes and 60 minutes, and this is most commonly a visual disturbance. So sometimes migraine sufferers will report some squiggly lines or bright lights. And then this segues into what we call the headache phase. So if you see here, the headache phase typically lasts 4 to up to 72 hours. And this is the most debilitating phase. So it is when you might experience nausea, vomiting, light, sound, smell sensitivity, the sensation of pain in your head, neck pain and stiffness. So that's really what most people kind of identify with as the migraine event. And then there's the postdrome period. So this can go on in some migraine sufferers for 2 days or beyond. And it's kind of termed the migraine hangover. This is when you're not quite yourself, you're feeling a little bit fatigued, and have mood changes. So I like this illustration because it shows really how complex this entire process is. But bear in mind, you don't have to follow this timeline to suffer from migraine. So some migraine sufferers don't perceive all of these things. So what's the problem with calling a migraine just a headache? Well, it really diminishes its impact. And there's some really astounding things that we know about migraines. So they're actually the second leading cause of years lost to disability in people under 50 worldwide. So that's huge. They can cause missed work, school, family events, have a huge impact on quality of life. And in Canada alone, there was a large study done of Canadian employees with migraine, and 56% of them had taken sick days, 23% were on short-term disability, and 18% were on long-term disability. So it really shows the impact it can have on people. So migraine is stigmatized, it's not recognized, and it's completely invisible. This is the challenge with a condition like this. I think interestingly, you know, we think about the things that are missed when people have a migraine, things like work, but rather than missed work, migraine sufferers endure something called presenteeism. And this is actually when they show up to work, events, to all kinds of things, despite suffering with symptoms. So for all the days that they may be off, there are a lot of days where they'll actually suffer through things. And this is often how more days are spent than missing commitments. So I think that sort of covers why it is not just a headache, and although a headache is one part, it's really so much more complex than that. So we're going to move on to myth number 2. Migraines are easy to diagnose. So first of all, migraine is incredibly common. So 4 million Canadians are estimated to have migraines, and that prevalence is higher than asthma, diabetes, or osteoarthritis, which are all quite common conditions. So to put it in a little bit of perspective, about 1 in 4 households will have a migraine sufferer living in it. That's about 15% of the population. We do know that women are affected 3 times more than men, so quite disproportionately. And about 1 to 2% of migraine sufferers have headache on more than 15 days out of the month. So we refer to this as chronic migraine, and that's quite a high number, 1 or 2 out of 100. So some of these pictures just sort of illustrate how common that is. So another interesting thing is it's common in children. So 1 in 10 or 10% of children will suffer from migraine. There is a strong correlation, certainly if one or both parents have migraine, it increases their likelihood, but it's not exclusive to adults. So this is why I think it's important that we recognize it. So how do we diagnose migraine? So this is something that's done by your healthcare provider, so a physician or a nurse practitioner. They're going to do a general health history and a headache history. Ideally, that really will go through a lot of details. Physical assessment and a neurological exam, which in the case of migraine, a neurological exam really should be normal. So we're not looking for anything in particular. We're actually looking for everything to be normal. That is the case in migraine. And what we really want to do is ensure there isn't a secondary cause for this headache. So that means that the headache, a secondary headache is a headache that is a symptom for another condition. Whereas migraine is considered a primary headache. The migraine itself is the cause for those headaches. There's internationally accepted criteria that helps us to categorize migraine. And then we arrive at something called a clinical diagnosis. So a clinical diagnosis means we put all these pieces of the puzzle together and it fits, and then the diagnosis is in keeping with a migraine. So there isn't one particular test that we read and tells us it's migraine. So it seems pretty straightforward, all of these things, but still, migraines are incredibly underdiagnosed and they're undertreated. So there's something going on here where we're kind of missing this. So we know that there are a lot of gaps in migraine care, and I think it's important to understand them from all perspectives of the players that are involved in migraine diagnosis. So we see here on the left, people with migraine. So they may just not suspect that the headaches or the symptoms they have are migraines at all. There's a lot of stigma, and there could be a lack of empathy, potentially from a healthcare provider, that they just don't feel heard or recognize that this is something significant. There could be poor access to healthcare. Many people don't have a primary healthcare provider, or they just may not seek care. There could be a perception of lack of options, particularly if maybe they've tried something in the past, it hasn't worked, or there's been not a good effect from it. There's also could be a perception of normalcy, that this is just, these are their headaches and this is what they live with. Misdiagnosis could be a cause. And there's a self-blame, which I think is always something important in migraine, because I hear this a lot, that people think, well, I'm not sleeping well, or I should drink more, or I should do this. And that's really a self-blame that is needs to be kind of dispelled and taken away, I think, from migraine sufferers. So then we have healthcare providers on the other hand. So We do, as healthcare providers, often focus on secondary headaches. So secondary headaches, again, are those things where something else is causing the headache, and we certainly don't want to miss something worrisome or emergent that needs to be addressed. We have a poor understanding often of the impact that these migraines might have on people living with them. So we don't feel the same kind of urgency to address them. Really, in healthcare, there is not a lot of education on the very, very complex nuances of managing migraine. So there's a lot that goes into managing them. And I usually say this is kind of a journey. It's a marathon in the relationship you build with a migraine sufferer and how you're managing them. So we don't have a lot of education dedicated to that in either med school or nurse practitioner programs. Time constraints, always a big issue, missed or misdiagnoses, and we may just fail to capture the frequency of patients' headaches. So that's a lot going on there, but really, what is the result? So 2/3 of migraine sufferers don't ever consult a healthcare provider for their headaches, and 40% of migraine sufferers just aren't diagnosed. As a result, proper treatment isn't offered, and this leads to a lot of, I think, unnecessary disability with migraine sufferers. So although the diagnosis piece it should not be that complicated, we're still missing the mark in a lot of ways. So brings us to myth number 3. MRI is needed to find the cause of my migraines. So are MRIs or CT scans needed to diagnose migraines? In short, no, it's not something that we need to diagnose them. So a healthcare provider may order one of these tests to assess for another cause of headache. So if there is a concern that this doesn't fit with all of those things, the exam is not normal or it doesn't really fit criteria for a migraine, then an MRI can be helpful. So if this is the case though, why not just scan everybody and make everyone feel easy? So what is the harm in scanning everyone? So there are some things. CT scans certainly expose patients to radiation. There are things called incidental findings. So these are discoveries that are made on images that are unrelated to the reason that the test was ordered. So we just find them. And as our ability to do these tests improves, as the technology improves, it's more and more common that we just find these little unusual things in different people's scans. So then what happens? So these can result in potentially additional testing, other referrals, and they can be a really significant source of anxiety. Focusing on some of these incidental findings can further delay treatment of migraines. And interestingly, there's a study that looks at the reassurance that, say, a normal MRI gives a patient, and it's often lost over time. So if the disabling headaches and migraines continue, then any of that reassurance that was developed after about a year is gone. There's, of course, a cost to the healthcare system. So these are resources that, we have to be mindful if there's really not a necessity to using them. And I think that sometimes this goes back to the myth that there must be some other cause for migraine disability since they are just headaches. So I think even in the process of getting diagnosed with migraines, people think, but a migraine is just a headache. So why do I have all these other things? There must be something else that's going on. When I think there just needs to be a lot more education that all of those things really do fit with migraine and it's not just a headache. So we do have a lot of data actually that shows that how often are MRIs found to be abnormal. And in somebody who meets criteria for migraine and has a normal exam, an abnormal MRI is very unlikely. So it's not different than just the general population. So it really isn't a test that is necessary in most cases. So this brings us to our misdiagnoses. So misdiagnosis 1. I have really bad tension headaches. So we're going to meet Anne. So this is Anne. She's 29 years old. She has had headaches since she was a teenager. They became more frequent when she was in university. She notices that she has headaches more when she's worried or she's stressed. She feels the pain. It wraps right around her forehead and to her neck. She uses over-the-counter medication, so things like ibuprofen, acetaminophen. They help a little bit, but she usually needs to rest in a dark room once they get really severe. She's tried massage and acupuncture, meditation, all kinds of things to relax, and it just really doesn't help her enough. So this is the story. So migraines are very commonly misdiagnosed as tension headaches. And so this is a nice little illustration here of some of the common symptoms that are present in either tension or migraine headache and how they can kind of get mixed up. So both-sided head pain, bilateral head pain, we say. So in tension headache, yes, this is the kind of head pain you have. It wraps around. But actually in migraine, about 40% of people will also have pain on both sides of their head. So I think we often hear about that one-sided head pain, but it's not always the case. Neck pain. So we think neck, and that's where tension and stress is. So certainly goes along with a tension headache, but still about 70% of migraine sufferers will also have neck pain. So that doesn't always sort of tease the two out. Light sensitivity, very, very common in migraine. It can happen with tension headaches. Sometimes people have a little bit and they're a bit bothered by light. Nausea. So this is not a feature of tension headache. So anytime somebody has a little bit of nausea, aversion to eating, this doesn't go along with tension headaches, but is very common in migraine. And then I think sometimes the most telling difference between tension and migraine is how it impacts your activity. So a tension headache really does not limit your activity, whereas a migraine certainly does, at least at some points. So if we kind of go back to Anne's story, she would have these headaches and they would get to a point where she would need to lay down. It was just too much. So this is a feature that goes along with migraines and not tension headaches. So colleagues that work in headache all the time developed this screening tool. So this is not meant to be a tool for diagnosis, but it definitely can help screen and maybe tease out some of those migraines that are maybe mistaken as tension headaches. So the questions are simply, in the last 3 months, when you have had a headache, did you have any of the following? Did you feel nauseated or sick? Did light bother you? Did your headache limit your ability to work, study, or play? And a yes to 2 or more of those questions means that this could have been a migraine. So I think sometimes, as migraine sufferers, these are important things to be aware of because it helps you communicate to your healthcare provider as well. And for healthcare providers, it's good for us to recognize some of these tools so we can sort of tease out the bottom and get to the bottom of these things. So often migraines just misdiagnosed as tension headache. Misdiagnosis number 2. My headaches come from my neck. So the relationship between neck pain and migraine. So this is a complicated one. So can migraines cause neck pain? Can neck pain trigger migraines? Can neck pain and jaw pain be related? And can jaw pain trigger migraines? The answer is yes to all of these things. So how do we untangle some of this? So I'll tell you a story. This is a very common story. So this is Matthew. He's 45 years old. He started having regular headaches in his 30s when he started a new job. It was high stress. He had to spend a lot of time leaning forward and he was reviewing paperwork. So he always has tension in his neck and his shoulders, and he would develop a severe headache a few times a week. He's had years of massage and acupuncture and physiotherapy and a personal trainer, and these therapies haven't eliminated his cervicogenic headaches, is what they have been called. So I think first it's important to understand what's going on here. So your head and your neck sensory networks are linked. So this means that pain in one area can be felt or referred to another area. So if you look here at this picture, there's the area in the head. These are nerves that are kind of interconnecting everything, the jaw area and the back of the head. So migraine sufferers commonly have jaw pain and neck pain. However, sometimes the migraine diagnosis is completely missed. So some of the diagnosis, and maybe some of you have kind of heard this or been labeled with this, that are made instead of migraine could be cervicogenic, which just means neck originating headache, tension headaches, occipital neuralgia, which is irritation of the occipital nerves at the back of your head, or TMD, which is kind of a broad umbrella term, temporomandibular dysfunction of the jaw pain. So you have your TMJ joint there, but so all of these things sometimes are what migraines end up being labeled as. So how do we understand the difference of what's going on here? So it's important to remember that about 70% of migraine sufferers will experience some neck pain and symptoms as part of their migraine. Poor posture, shoulder tension, especially, all of us sitting in front of our computers, maybe from our makeshift home offices, can certainly be a trigger for a migraine. Jaw pain from clenching and grinding. This can be a kind of a stress response, but it can also be associated with neck pain and it can trigger migraines. So what do we do? I don't think that I've really untangled this kind of mess yet. So I think it's important to remember that we recognize that this is an interconnected process. So certainly exercise physiotherapy can help with postural triggers. Jaw problems may need to be assessed and addressed. You really do need a proper assessment of your head and neck, but ultimately the migraines need to be treated. So in cases where the headaches are all coming from the neck, I think a lot of times those of us who work with headaches all the time see people that spend a lot of time thinking, if I take care of the neck, the head pain will go away. But really, truly, if it was just the neck, then that would resolve all of the issues. So the migraines can't be neglected in this, and a lot of times treating them effectively will improve the neck pain as well. So that brings us to our third misdiagnosis. I have chronic sinus headaches. So this is Margaret. She's 41 years old. She has had frequent headaches her entire life. She notices that they're associated with weather and season changes, and she describes pain around her sinuses. Her eyes become watery and sensitive to light during these episodes. She takes cold and sinus medications and nasal sprays on a regular basis. She's even seen ear, nose, and throat specialists, but she hasn't had any relief. So Margaret tells you that she's got chronic sinusitis, and she knows that her headaches will improve if she can just clear up her sinus issues. So migraines are commonly misdiagnosed as sinus headaches. So research has shown that 75% of headaches thought to be sinus headaches are in fact migraine. They meet criteria for migraine. So how are we confusing these things? So in migraine, it's actually very common to have pain over the sinus areas, and it can be a very throbbing pain. And actually, tearing and nasal congestion can be quite common during migraine attacks as well. Another thing with migraines is that they can be triggered by weather changes. So, this kind of goes along with, is it my allergies? Is something going on with my sinuses? And it's a common time to trigger migraines. So why is this important? It's important because migraine and sinus infections are treated completely differently. So a lot of times, in the case of a sinus headache or sinusitis misdiagnosis, patients may have or headache sufferers may have lots of courses of antibiotics, a lot of nasal sprays, and this goes on and on and on, and it doesn't always address the cause. Typically, in the case of sinusitis, you're going to have other things. The discharge will be a lot more discolored. You might have a decreased sense of smell and other things that go along with being more acutely unwell. So a good thing to be kind of mindful of. So segueing into the misconceptions. So misconception number 1, I have regular headaches plus migraines. So separating headaches can sometimes miss a diagnosis of chronic migraine. So in people with migraine, they very, very commonly will talk about their most severe or disabling headaches. And oftentimes there's some other milder type headache that they have on other days that, probably isn't as, significant and they're quite fine with. So what ends up happening is that when, we're talking about the frequency of headaches, people with migraine may only talk about those really, really disabling episodes. But what we're trying to look at is whether or not these are chronic migraines. So this simply means that headaches are present on 15 days or more per month, and they don't all need to be migraine type headaches. So people with migraine can be really prone to other types of headache. So we now believe that even those milder headaches between the severe migraines are part of the entire migraine process. And sometimes what can happen is somebody may have a few days of the severe migraines and then a lot more of the milder headaches, but over time they can transition. So you might start to have more frequent, more severe episodes. So it's good to kind of intervene and address this and get them taken care of earlier. So how can you kind of sort this out and what can you do? So you can track your headaches and track all of them. So there's a fabulous tool made by Migraine Canada, the Canadian Migraine Tracker. This is something that I definitely recommend for everyone to use. It uses a very simple scale, 0 being no headache, 1, 2, or 3 being mild, moderate, or severe in terms of its impact on your function. You can track as much or even as little information as you like. So how many headache days and how often you're using your medication to treat them. And this is an invaluable tool, both for your own kind of knowledge of migraines, but also to communicate with your healthcare provider. So I do recommend that. Misconception number 2. Over-the-counter medication is safe to use daily for my migraines. So we're going to meet another gentleman here. This is Lawrence. He's 36 years old and was diagnosed with migraines in his 20s. He used to get migraines about twice a month, and he was prescribed a triptan. So it's a prescriptive medication to treat migraines. And over the last 10 years, his migraines have become more frequent. So he uses different combinations of medications, including sumatriptan, Tylenol 3, ibuprofen, at least 5 days out of the week. So all of these medications are becoming less effective at treating his headaches. So this is a really common story, especially in migraine sufferers that have chronic or very high frequency number of headaches. So a medication overuse headache is actually a headache that is caused by taking those acute medications too often. So acute medications are the medications that you take when you have a migraine or a headache event and you want them to work quickly. They'll work within an hour or two. So when you use them more than 2 days out of the week, you're at risk for a medication overuse headache. So about 50% of chronic migraine sufferers actually experience medication overuse. And how do we know that this is causing a worse headache or adding on to this? So research shows that when medication overuse is stopped, about 60 to 70% of people will have headache improvement. So the takeaway message from this is that if you need to treat your headaches or your migraines on 2 or more days out of the week, you should really speak to your healthcare provider. So often this means that some kind of preventative treatment is needed. And there's a really great post as well on Migraine Canada for medication overuse. So if this is something that you are not familiar with, or you think you're kind of verging on that, it's a great post that talks about really what's happening here. So you end up with kind of this rebounding effect to your headaches, and they kind of, you need more medication because they're more often, but when you take it, the headaches kind of get worse. So although over-the-counter medications can be quite safe if you're taking them, as directed and within typical limits, it's very tricky when it comes to migraine sufferers whose brains are just a lot more sensitive to these things. And misconception number 3. There's nothing more that can be done for my migraines. So this actually is a really exciting time in migraine care. And I think that it's a great time for people to be able to understand their options. So if you experience headaches of any kind, migraines, if a loved one or somebody who has migraines, which given how common they are, it's probably the case, visit Migraine Canada. There's a wealth of information there. And migraine management really involves so much more than medication. So I kind of put this circle up here. So there's acute treatments. These are the things that you take when you have a migraine. There's a lot of preventative treatments. These can come in the form of medication and supplements, and there's a lot of other things that can be done. And then there's lifestyle and behaviors as well, and that plays a role. So new options are becoming available all the time. We've made a lot of really interesting advances in terms of our understanding of migraine. There's new medications that have come to market, and there's a few more that are coming shortly. And then how do you kind of find a healthcare partner to navigate this journey with you? So I think that communication is really important. So something like tracking your migraines and using Canadian Migraine Tracker, as well as your medication use, can really help to better communicate with your healthcare provider what's going on and really help them to maybe understand, because you do need a bit of a partner on this journey that can untangle some of the things that are going on. And that brings us to the end of our talk tonight. Thanks, everybody. Have a great night.